Assalamualaikum warahmatullahi wabarakatuh and a very good morning. First and foremost, I would like to thank the organizing committee for allowing me to deliver this plenary lectures in our emergency medicine annual scientific meeting for 2021. The topic that has been given to me actually is very much close to my heart. It's not just me, but all of us here as an audience or participant in this particular conference. How that we as a frontliners overcome the issues of COVID-19, looking back at our journey and subsequently reached to the current level we are going towards endemics. So I have no conflict of interest, but I would like to thank Dr. Nafisa Idris for contributing to the slides content, and of course to all the emergency department staff who actually relentlessly contribute their energy for the betterment of this service, especially during the pandemics. This is our journey, the emergency medicines and trauma services journey. The journey that we have gone through for more than a year already, facing the challenges that we need to overcome, which is unprecedented in the history of mankind. Facing the challenge of COVID-19 is very difficult, is very challenging to many of us because it never happened in the past before such scenario occurred. What are the challenges for us? First and foremost, actually, if you look, COVID-19 itself actually is a new disease, which is very much unsure of identity, come with undifferentiated differentiation. And having said that, the system that we have in our country at the moment, our healthcare system, there is a clear dichotomy in governance, maybe it in the public health side versus those in the medical side that all of us involved. Secondly, there are no unified command between the states. The states has its own autonomy in a way in managing the disease or the situation that we face. So working in silos make us more difficult and more challenging for us actually to comprehend the issues that we have at hand. Thirdly, the ongoing issues of insufficient structures and equipment, and also lacking behind in terms of the technology that we have available in our emergency department to cater for such needs. Number four, the issues of human resource. We have so many new and junior staff in our department, which is unskilled, that need to be skillful in this particular disease. And on top of that, learning new things about the disease, which is very much itself is dynamic in terms of its progress. And for those who are skilled workers, that's all of us, specialists, so on and so forth, we need to learn new skills in order for us to adapt to the challenge that we face during COVID-19. And we want to conduct a training, but we are actually obstruct or have an issue with regards to physical face-to-face training because of the issues of unsurety of the way that on how the disease might affect the others during the training. And last but not least, the issues of the financial constraint. So he's looking at this particular presentation. First and foremost, we look at the challenges during the outbreak. We look at the timeline recap throughout the pandemic period over a year or so. And then we look into the fourth wave initiative, the amplification of the various measures that we put in during the first to the third wave that we face in our country. And then we face at the pinnacle or at the peak of the pandemic, where actually the hurricane and the tsunami come along, that we have to work beyond the surge capacity of our department. And from then on, actually, we are moving towards the endemics. What stays, what are the opportunity arises, and we have to look at the various collateral damage that arise from this particular situation. So bear with me. These are our journey, that hopefully that is going to be a legacy for those in the future to reflect back on what can be done during such situations. If you look carefully, you look at the journey, the timeline, actually when we got to know about these particular diseases in way back in December 2019, And then there are first reported cases in January 2020. And then we have the first wave, which is in 2020. And then by September 2020, we have slight increment of the cases in our countries and start to peak again in February 2021 because of the certain circumstances that occur in our countries. And of course, we're going to face the fourth wave June onwards. So during the first and the third wave, or the initial wave of this particular disease that come to our shores, there are several initiatives and innovation were already made to adapt to face the particular storm or to face that particular challenges. So what do we do during that time? We come up with the system changes where actually the fundamentals of the triage system, which is to screen, to detect, to isolate, to test, and to treat. And we actually come up with a system, convert our triage system, which is solely based on severity of disease in order to manage the patient, that we convert it into a binary triage system, which is looking into not just infectivity, but looking at the severity and infectivity of the patient before the patient being managed in the various clinical zones. It's not just that, we come up with a different clinical approach in managing such patients. We're using a focused examination with extended tools, utilization of lung ultrasound, less touch, but maximal inputs in terms of the patient clinical data, and therefore able to make critical decision. And in terms of the governance of the way that we manage the cases, actually, we have an intra-departmental monitoring system, daily briefing and updates, and also we have an exit plan disposition to the various wards based on the centralized bed management system in our facilities or in our institution. And importantly, after that, we come up with the measures of safety. It's not just for our healthcare workers, but also safety for our patients. So we put in place the practice of personal protective equipment, the donning and doffing, training, the methods on how best to conduct an intubation using a PAPR, video laryngoscope, closed suctioning system, so on and so forth. We changed the system of managing asthma patient rather than a nebulized oxygen. We convert into using an MDI. And then in terms of transfer circulatory patient, we're using eye support. And there is establishment of what we call a Zulu team, or a specialized team, then only dedicated for transport of ill patient of COVID-19. And we also come up using a tools that which is focusing on less human touch and using a mechanical CPR, for example, for us to conduct the routine chest compression for those patients that are arrested in our department. What else? Importantly, we come up with the structural zoning. The zone in the emergency department has to be divided between a clean and a dirty zone. There are establishment of negative pressure areas to isolate and to manage this patient in order to avoid or minimize cross-contamination or transmission to the healthcare workers and vice versa. So these are important aspects that we have to face or we have to establish in order for us to overcome the challenge of infectious disease of COVID-19. And then followed by enhancements of the necessary equipment, the medical equipment stockpiling. It's not just via procurement, but also there's lots of donation that we receive from the NGOs and the various friends out there that assisted us in getting this particular equipment. It is not just medical equipment, but also the various consumable as well to cater for such issues that we have with regards to COVID-19. And for staffs as well, what do? We're focusing on the staff, the skilled workers, or the staff distribution. There's a lacking of staff in many departments, especially in emergency department, in ICUs, in the medical, so on and so forth. So there was a staff redistribution, pulling of staff from other departments within the hospital setup or within the states. And importantly, actually, we conduct a regular training with regards to the staff and safety or patient safety in terms of PPEs, hand washing, distancing, swabs, so on and so forth. So in summary, when we talk about the staff safeties or the training of the human resource, we need to train those that are unskilled to become skilled workers. We need to train the skilled to gain new skills. And we need to protect them from the assault of COVID-19 by ensuring the adherence to the PPEs, using a necessary triage system, and isolate the patient early. And importantly, the governance of role modeling from top to down, which is from the specialist and consultant, actually leading the battle from the front. So this by itself will give a role modeling to the junior doctors and the other staff actually to come along and work together as a team in order to manage these difficult issues. So when we look back at the timeline, those are the various initiatives that we come up with actually during the first few waves of COVID-19. And we thought with these strategies and adaptation are enough to face the subsequent wave. But we are wrong. Not 100% wrong, but what important, the fundamentals that we put forward in this initial few waves serve as the pillars for us to what I call face the biggest challenge in the history of mankind in our country. So in March 2021, where I see the vaccinations start to kick in, we heard the issues of variants of concern or Delta variants. And by May and June 2021, we start to see an escalation of the numbers of cases that flooded our emergency department. It's beyond our imagination that patients have to be queued to enter a resuscitation zone. That's beyond our imagination before that our asthma bay need to be converted into patient management areas. So we have to optimize every single corners of our department, the corridors, so on and so forth, maximizing the cubicles that we have in our zones in order to cater for such needs. We do realize by increasing the capacity itself, it's important for us to deliver or to manage the COVID-19. We do realize by having a space itself is not enough. The capacity enhancement involve increments numbers of the oxygen spot or oxygen outlets for us to manage COVID patients, because the issues of hypoxia need to be addressed urgently. So it's not just expanding the space, but we also have to have an initiative how to increase, to maximize, to increase, to further enhance the availability of oxygen support to the patients. So this is where actually another initiatives come along, where actually there is a procurement and donation of oxygen concentrators and utilization of oxygen tank in the various areas in the department. It's not just that. We realize by using this particular initiative, such initiative actually is very much labor intensive. Then actually we come up with another issues of human resource that have to do extra work in order to get this equipment in place. And we're also utilizing a semi-permanent structure like canvas and tanks for the management of our patients. So new human resource coming, new medical staff coming in, but they have to be subjected to a vigorous orientation and training program for them to prepare physically, mentally, and also emotionally to face the challenge. So we come up of these various initiatives in order for us to overcome the issues of redundancy in terms of tasks. So, and therefore, during the fourth wave, one of the first things that we do, we created an automation of tasks. What does it mean? Meaning that we incorporate a system, a factory-style system, a conveyor belt system, where actually there is a standardized patients management scheme from the word go, by every time at the point of input to the emergency department. So we come up with the standardized patient clerking notes, we come up with the standardized progress notes, and then we come up with the centralized bed management system to ensure an appropriate or timely disposition of the patient from emergency department. So We come up with an automation system to pass over during the shift. Very simple, just sheets of papers that listed out names and the various conditions of the patients that need to be looked into during passover. We come out with this standardized investigation for swab, chest rays, and blood investigation for all the COVID patients that come to our department. And then we also come out with a patient tracking and disposition system, where actually the formation of the IT teams by using the computer installed in the zone to ease the data entries. This by itself actually ease the issues of monitoring and tracking the various movements of the patient from the front end to the back end of the department. Importantly, we look at the perspective of the relatives as well. So we need to come out with the real-time sensors to the where and whereabouts of the patients. So they are looking for their loved ones because they can't come to the department to visit the patient. So we have to come up with another initiative by working together with our communication corporate or our public relation officers in order for them actually to assist the relative to track their loved ones. So this is important for us actually to realize it's not just in the perspective of us as a healthcare workers to ensure that we are in the know of the patient's clinical condition, but also it's important for us to relay that message to their relatives. Then another surge comes along, the hurricane and the tsunami. We thought what we have done during the first, second, and third wave is enough for us to cater the hurricane and tsunami. We are wrong. The ongoing assault to the system is very much affecting all of us. We don't have enough space. We don't have enough equipment. We don't have enough people to cater for such needs. This is where actually all of us start to come up with new ideas and innovation in order for us to overcome. So we need to pray to the God Almighty to give us the strength to overcome these challenges. Because we believe with the hard work that we put in, with the God bless, all this can be overcome. So we come up with innovation, how to, what we call, redistribute the oxygen to the various patients. By using such a initiative that come out, it's not just in the various emergency department utilizing this method. From one oxygen tank, we're able to supply the oxygen to about 4 or 5 patients. And we're using methods of EMAS communication. For example, in these particular pictures, where actually the physiotherapist actually giving instructions how to conduct physiotherapy to COVID-19 patients. So this is unthink of in the past, but in the event where actually such situation arise, these are the various methods of communication need to be applicable in the way that we're managing the patients. We are maximizing the space. One cubicle that's supposedly for one patient, but utilizing 2 per cubicle or even 3 at a time for us actually to ensure that we have enough space for our patients. And I'm sure many of you have seen this particular video, which is viral in the midst of July, 2nd of July. Humbly, this is actually our decontamination room that supposedly only to manage 4 patients, but at that time need to deal with up to 30 patients. So, and therefore we realized that when it comes to beyond surge capacity, the walls of emergency department, not just HKL, but also other emergency department, is not enough, even just to cater for such surge. And therefore, there must be a strategy to distribute the patient beyond the hospital wall. And that's why there needs to be a change in the system. So what do? We start to decanting our patients. We're outsourcing the stable COVID patients to MAEPs. We send them out. We up to category 3 to MAEPs for those in the Klang Valley, to do all to the PKRCs in other states. And then we redistribute the post-COVID patient or the off-tax patients of COVID to the step-down care in the various district hospitals. What else do we do? Importantly, we started off to outsource our non-COVID patient to the private hospital. This initiative was first done by at HKL, where actually we start to outsource the emergency cardiac services to the private hospital. And 2 weeks after that, we start to decanteen or outsourcing the other non-COVID patients to others private healthcare facilities. By doing this, actually, then we realize we create more and more beds for our COVID patient to be managed in our institution. It's not just in HKL, but this initiative actually has been put in place for the whole of the Lembah Kelang Hospital. It's not in Lembah Kelang, but now also even this initiative is being done in other states as well. And then we have to come up with a different system how to transport the patient. The existing fleets of ambulance in the Ministry of Health is not enough. It's not just inadequacies of the numbers of ambulance, but also inadequacies of the human resource to man those ambulance. So we come out with a bus ambulance to EMAS transports of the patient from MIAP to the various hospital. So, and we are outsourcing the private ambulance services to ease our burden in transporting such a patient as well. So, and then the enhancing the capacity beyond the walls of the hospital with the establishment of field hospital in the various states in Labuan, Selayang, Kelang, Melaka, Johor, and Pahang, so on and so forth. So these measures is very much necessary and needed during the beyond surge capacity during the hurricane and mobilizing of human resource. We are using non-medical officer to carry out certain service provision in our department. We are having people from outside that less affected states to come to our centers to help out. So, for example, for HKL, there are medical officers from USM, from Langkawi, even from Temelloh to come along. And we have a physician from Sarawak to help us out actually in managing the current situations. Managing the patient is important, but what more important also is to assist the healthcare workers of their psychological needs. So we come up with their various initiatives to keep them continue to be motivated in ensuring they deliver the best practice in during these fights against COVID-19. And we have lots of collaboration from the NGOs, which is donating medical equipment, non-medical equipment, so on and so forth, in enhance of our medical equipment stockpiling in the department. It's not just that, there is an initiative also how that we can improve the efficiencies of dead bodies. So this is also a major challenge where actually the loved ones wanted that there will be an expedite or the fast movement of the dead bodies in the department, also from the hospital, to make sure that they've been dealt with respect. And at the same time, the learning curve still continue. By doing the COVID M&M, which is become a routine or daily practices rather than weekly practices initially, we learn from the cases. So we realize there's more younger patient, obese patient that actually involved in the death of COVID during COVID. And this is then later on, all this lesson learned will be quickly translated into the clinical management to decide which patient that we need to treat aggressively, which patient that we have to realize that we have to humbly palliate them in order to ensure they have the best care during their illnesses. And the ongoing training become more and more important. What we need to realize actually, emergency department is not just involved in identification of COVID-19 or the initial resuscitation of the cases, but also emergency department have to provide the end-to-end management from not just at the point of entry, but also at the point of disposition that include discharge to the community. So we have to learn the new skills, or as a emergency physician, how to manage patient that with us up to 5 days, 7 days, 10 days, even 2 weeks for that matters. So we have to seek an expertise from our colleague in the infectious disease department, in ICUs and the respective physician for us in assisting us in managing COVID-19. So by doing these types of training, then we are more prepared in managing COVID-19. It's not just at the point of identification and also resuscitation, but also at the point of the daily monitoring, intervention, and also plan of discharge disposition as well. Now we recap back at our journey. So when the vaccination program or the program imunisasi COVID kebangsaan continues from March to July, then by having all the initiative, with God bless, actually the numbers of the cases starts to come down. Then we need to prepare ourselves on how that, from all this assault, how that we can move forwards towards the endemics. After the fourth wave, after the assault, we realized that the provision of emergency and trauma services changed forever. There are many things that we have done during the pandemics or during at the height of COVID-19 need to be continued. Why is that? Because the threat of infectious disease is there. The system, which is not available before, now become part and parcels of our system. So the paradigm of managing patients that coming to our department now change. So what actually happened during post, what I call at the peak of COVID-19? Our binary triage system and the structural organization of this department stays. Either we like it or not, there must be a clear provision for clean and dirty patients to come to our department. In the past, we have a similar provision, but the portions are very small. I think it's timely that we realize with the threat of infectious disease, not just COVID-19 and what more that lies ahead, that these undifferentiated patients who have a potential to become infectious need to be detected and isolated early. And therefore, the provision of structures in this department will stay as it is. There is a component of dirty zone, isolation, with a proper structural and environmental assistance to support, to isolate, to minimize the transmission, and also an area where actually the patient can be treated as a clean patient. What stays? Now we have so many skilled human resources in our department who actually were probably unknown to many. We do not know lots of about COVID before this, but now we have so many of us actually well versed about the COVID management. And what else that we gain from this experience? We have the structures and medical equipment capacity to cater for any another surge. Hopefully, we don't have to face it. But what important now, if we face with another situation in the future, we already have the necessary structures and medical equipment in terms of to cater for such needs. It's not just opportunities alone, we also have to count what are the collateral damage. So we realize that our doctors need to relearn the skill that they lost during pandemic or during at the height of COVID-19. We realize now there are lacking of experience and expertise to manage a simple trauma patients, to manage cases other than COVID-19. Some of us have to relearn that particular skill that we lost over the last few months. And what else that the collateral damage that occur? There was a significant financial strain to the system. Though that we have received lots of donation, there's a lot of procurement during when our time in needs to manage such a patient, but we realize in the coming years, the financial support will not be as good as we have over the last year or so. So once things start to get better, So what we have to share with others. So the equipment that we have, we distribute to others hospital that it needs. Our human resource also begin start to go to the various states in Malaysia in order to assist them in managing the waves of the COVID that start to come to their shores. So this is how actually we as EMTS providers come together, giving and helping hand to those who are in needs. So what do we learn from this particular journey? Importantly, we realize that resilience is the key. I think the hashtag of Kita Jaga Kita, the hashtag of no hierarchy is of a vital importance for us to overcome this. Secondly, what do we learn? We realize that the deficiency in our care system, the dichotomy of governance. So we learn also they must have a unified command system for us to manage this. The dichotomy of governance between the public and the private sectors need to be overcome as well. And thirdly, we realize there's so many innovations and creativities come along in overcoming the surmountable challenges. So in order for us to come up with the innovation and creativity, we always focus on the values of the product that we need to come up with. Number 4, what do we learn from this journey? We're able to have a good networking. We have friends in our NGOs. We have friends in others institutions apart from Ministry of Health. So we make more friends, and please do not create any enemies. And last but not least, we have to be very honest and transparent in the way that we do things. We need to state the truth. Saying the nice thing is not the way. The way forward is to be honest and transparent. So all of this cannot be done without the blessing from our God Almighty. So I do hope this particular presentation will give an insight on how we, emergency medicine and trauma services, comes together facing this particular challenge and later on arise actually to come up with to face another challenge in the future. So to end this particular presentation, I will leave you with this short video, which is a tribute to the EMTS frontliners. With that, thank you very much. Thank you again for allowing me to deliver this particular plenary. Sekian, Assalamualaikum warahmatullahi taala wabarakatuh.